Due to increasing evidence of the causes of cervical cancer, in 2008 the Department of Health launched the National HPV Vaccination Programme. The vaccination used within the programme is Gardasil. The vaccine contains antigens HPV 16 and 18. These are known to cause at least 70% of cervical cancers. Therefore, it's believed that the vaccine will have a direct impact on the incidence of cervical cancer in the UK. It is anticipated that in the long term, it will reduce this by 60%. The key objective of the programme is to deliver 3 doses of the vaccine to girls before they become at risk. It is important that for healthcare professionals who are administering the vaccine, that they not only educate the girls around the vaccine, but also educate them around safe sex and to encourage them to attend for future cervical screening. From September 2012, the vaccine that should be used is Gardasil. For any girl who has commenced the course using Cervarix, the course should be completed using Cervarix. These figures show the annual uptake of HPV across the UK. You can see that there is a decline with the 3rd dose of the vaccine. We can see that there are variations across the UK. Factors that can affect uptake include the size of the population, the workforce available to deliver the vaccine, the rurality of the areas where the vaccine may be delivered, and cities and large populations. The vaccine programme consists of 3 doses. It is essential that healthcare professionals communicate the importance of this to the girls and encourage them to attend and have all 3 doses to achieve maximum protection from HPV. For those girls who miss doses, there may be opportunity for school nurses or others going into schools to offer them a catch-up or to direct them to primary care services. There are a number of ways that healthcare professionals working alongside parents and young people themselves can increase the rate of compliance. Good quality and creative health education and promotion are essential. Healthcare professionals can use this as an opportunity to empower the young girls to take responsibility for their own health and future health protection. Actively listening to them and responding to their questions is an essential component of increasing compliance. When planning vaccination sessions, particularly in school or youth settings, healthcare professionals should have good management systems and processes in place, particularly around issues such as fainting, which may encourage mass hysteria and increase refusals. For some of our most vulnerable and excluded children, vaccination may not be very high on their or their family's agenda. For these hard-to-reach groups, healthcare professionals need to consider if there are any barriers that they can help with. Such barriers may involve finance, transport, language difficulties, and faith issues. Healthcare professionals may need to offer creative opportunities for vaccinations to be had. Some examples would include taking the clinic to more rural areas, offering drop-in sessions in community settings, youth clubs, and evening sessions in GP surgeries. Healthcare professionals may need to consider if they need an interpreter there for girls where there may be a language barrier. They may also need to meet with governing bodies of schools to discuss faith issues and to support them in developing policies which allow vaccinations to be delivered in school settings. It's important that healthcare professionals such as school nurses and GPs have good communication systems in place, have a shared responsibility and accountability to ensure optimum uptake of the vaccine. The healthcare professional is responsible for ensuring that they have obtained consent prior to administering the vaccine. The healthcare professional must ensure that the person who is giving consent understands what they are consenting to and fully understands the benefits and any risks associated with the vaccine. Ideally, the person with parental responsibility will give consent for the girls to receive their vaccinations. However, if the young girl is deemed to be competent under the Fraser Guidelines, previously known as Gillick competence, then the girl herself can consent to have the vaccination. Although the consent obtained at the beginning of the programme is valid for all 3 doses, it is best practice that the healthcare professional checks the consent prior to giving each dose. In summary then, the National HPV programme is targeted at girls aged 12 to 13 in order to achieve maximum protection from HPV. It's essential that healthcare professionals communicate to the girls and their parents the importance of having all 3 doses of the vaccine.